Okay, so in this lecture, we're going to be discussing acid-base disorders. The references for this lecture, as noted at the bottom of the slide here, are primarily the Sabiston textbook, Chapter 5, written by my friend and former Navy colleague, Dr. Rich Mullins. I think Rich did a great job with this chapter, and we're just focused on the acid-base portion of that chapter, which is pages 81 through 90. I think he does a good job of creating an overview of not just the mechanics of acid-base balance, but also the clinical relevance of certain conditions. Also, I think, though, supplementary to that is the Marino ICU text in chapter 28. Dr. Marino, I think, does a maybe a little bit better job as far as just with the nuts and bolts of actually how to calculate and determine acid-base disorders, particularly the mixed disorders. I will also be providing you either on CD or by email with just a summary of the acid-base approach handout, which personally I carry around to help me on a day-to-day basis in the ICU or even sometimes on the floor. Acid-base disorders certainly are one of the most common problems that we deal with in the ICU. It's been estimated that 80 to 90% of ICU patients will, at least at some portion, during at least some portion of their ICU stay, have some issues with acid-base abnormalities. So very important and something that we certainly deal with on a daily basis, and important that you have a fundamental and strong understanding of this. And acid-base homeostasis is essential because if you lose it, you lose normal physiologic function. And really, as you'll see as we go through the year here in the ICU lectures, it's all about homeostasis and the ability for the patient's body to maintain a steady state or homeostasis. And nowhere is that more important than in the setting of acid-base balance. It's important because if your acid-base balance is thrown off, your contractile protein function becomes deficient and problematic, and in particular we're worried about that in the myocardium, and I've actually seen patients with profound acidosis, and you basically can see arrhythmias and poor cardiac output, and then as soon as you correct that acid-base balance, those issues will oftentimes go away. Enzyme function, particularly the imidazole portion of histidine amino acids as portions of enzymes bind protons, and if they're bound excessively, that can throw off the functions of many of the enzymes that are responsible for our normal biochemical functioning. And clotting factor function also is dependent upon a normal, or at least a close to normal pH. And indeed, when we talk about trauma patients, we talk about the triad of death, which is the most common thing to kill trauma patients other than outright bleeding, and that is the combination of metabolic acidosis and coagulopathy and hypothermia. And as the patients become acidotic, the clotting factors do not function appropriately. And so it's for these reasons that acid-base homeostasis is essential to the survival of the patient. Just some definitions by means of introduction and just review. Acid is obviously a hydrogen or a proton donor. Base is a hydrogen or a proton acceptor. And the acid-base status is reflected by the hydrogen concentration, with a normal hydrogen concentration being about 40 nanoequivalents. And I think Dr. Mullins does a good job of emphasizing that we're talking nanoequivalents here. That's a million times smaller in quantity than the normal milliequivalents that we typically talk about when we talk about potassium or sodium levels. And so the amount of acid floating around in the bloodstream is very, very little, but once again is very important. And because of these numbers being so small, we typically express the amount of hydrogen or the amount of acid present as the pH, with an increase in the amount of acid present being reflected by a decrease in the pH. And the textbooks will, talk a lot about the mathematical formulas to derive pH, etc. I don't find that that's particularly helpful, but certainly understanding the relationship is. By definition, of course, acidosis is a pH in the bloodstream of less than 7.35. Alkalosis is a pH of greater than 7.45. So your normal acid-base range is 7.35 to 7.45. If you get above that, it means you don't have enough acid present and you're alkalotic. If you get below below that, it means you have too much acid present and you are acidotic. When we speak of acids, there are two categories of acids that we're dealing with, volatile and non-volatile acids. For the most part, when we speak of volatile acids, we're speaking of carbonic acid. Carbonic acid, we're going to see, is very central in understanding acid-base balance. There's a lot of it in the body, between 15 and 20,000 milliequivalents per day. Of CO2 is produced by metabolism, and much of that goes through carbonic acid as an intermediary between the uncharged and easily diffusible carbon dioxide and water and the charged hydrogen ions and bicarbonate, as you can see listed here. A very important relationship to understand, and that's why this acid is called volatile. It's volatile in that it can be re-equilibrated after being transported in the bloodstream back to carbon dioxide, and then can be breathed off. It can be ventilated off, so and that means it's volatile. And so this is a very important acid-base formula, if you will, here, the understanding of how carbonic acid is the intermediary between free acid and bicarbonate, both charged particles which cannot easily traverse membranes. It takes, energy input to get a charged particle across the membrane, and certainly we see that, and we'll talk about that in the renal secretion of bicarbonate. However, just breathing carbon dioxide off and water, those are able to go across membranes, and so you do not require energy to do that. So those are uncharged, easily diffusible molecules, and that's what makes the carbonic acid so important ultimately in acid-base balance, and we'll talk more about that a little bit later. Non-volatile acid, meanwhile, are acids which cannot be breathed off. These are a much less significant player, and so something that we often regard as even negligible, between 50 to 100 milliequivalents per day of non-volatile acid, such as sulfuric acid and albumin, which are produced, which are certainly, I wouldn't say irrelevant, but not mathematically significant when compared to the 15 to 20,000 milliequivalents per day of carbonic acid, which is produced. So as we look at overall the determination of systemic pH, assuming that you don't have excessive amounts of these non-volatile acids floating around, which there are pathologic conditions when those become relevant, but assuming that you're not dealing with a condition such as that, then really it's the carbonic acid balance, the balance between, on the left side, the carbon dioxide, and on the right side, the bicarbonate, which determines the pH. If you have excessive amounts of CO2, then you will be acidotic. If you have excessive amounts of bicarbonate, then you will be alkalotic. This can be expressed by the Henderson-Hasselbalch equation, which all of us will at least have some vague recollection of from biochemistry. I don't find that all that particularly helpful clinically. I think the Henderson equation showing that the concentration of acid is proportional to 24 times, the concentration of acid is proportional to the PaCO2 over the bicarbonate amount is, I think, very clinically relevant, where basically you see that the body's goal to maintain equilibrium is to keep this fraction, keep this relationship, keep this ratio equal, such that if your PaCO2 goes up due to some pathologic state, your bicarbonate's going to go up to balance that out. In similar fashion, if your bicarbonate goes down, let's say, then your PaCO2 is going to go down to keep that ratio balanced and to keep the body in acid-base homeostasis. Okay, looking at acid-base disorders, there are 4 of them. And obviously there are 2 metabolics and there are 2 respiratory. If you're acidotic due to a metabolic cause, that's metabolic acidosis, obviously. If you're at the opposite end of the spectrum, it's metabolic alkalosis. On the other hand, you've got respiratory acidosis and respiratory alkalosis. The abnormality with metabolic acidosis is a decrease in the amount of bicarbonate which is present. The compensation, again, to keep that ratio the same, is to decrease the PaCO2. So a clinically relevant situation in which we'll see that is a patient with significant lactic acidosis comes in, maybe has bled out or has become profoundly dehydrated due to some problem of a surgical nature, and that will decrease the amount of bicarbonate that is present due to the lactic acidosis which is occurring. And the way the body compensates for that is you breathe faster. You breathe faster in order to decrease the PaCO2 to maintain your pH at an acceptable level. Metabolic alkalosis, on the other hand, the abnormality is you have too much bicarbonate relatively floating around, and the compensation for that is you increase your PaCO2. So those patients may tend to hypoventilate a bit. Respiratory acidosis, on the other hand, the primary abnormality is an increase in PaCO2. For whatever reason, you've got ventilatory respiratory failure, you're not blowing off enough PaCO2, maybe the patient's over-sedated, or they've got other problems which are overwhelming them and preventing them from ventilating normally, so the PaCO2 climbs. The body attempts to offset that as much as possible by increasing the amount of bicarbonate present. Respiratory alkalosis, the patient's breathing too much, blowing off too much CO2, and so the PaCO2 is decreased, and you see in a compensatory fashion decreased bicarbonate. And this seems very straightforward, but it becomes a little less than straightforward as we start to deal with clinically relevant conditions. Okay, well, let's talk about how the body maintains the regulation of acid-base balance. There's basically a threefold level, if you will, of acid-base regulation. The first line of defense are buffers, which begin to work immediately to within minutes. So buffers start to work very quickly, followed by respiratory compensation, which begin in minutes and usually becomes complete within a fairly short period of time, certainly within hours. And then renal compensation, which takes a while to kick in. You do start to see it start to kick in within the first 6-7 hours, but overall it's not the complete amount of renal compensation you're able to get. Takes days to develop. So a threefold level of acid-base regulatory mechanisms: buffers, which start almost immediately, respiratory compensation, which starts within minutes, and renal compensation, which starts within hours but is not complete for days. Now, one thing that's very important to recognize is that you cannot fully compensate, and you can't overcompensate. So let's say you have a patient that their bicarbonate's low, but their pH is actually high. Well, probably you are going to have a mixed acid-base dysfunction there, because compensatory mechanisms cannot overcorrect and actually make the pH overcorrected, and you can't come back to a normal pH of 7.4. So when you see a pH which doesn't make sense for either the PCO2 or the bicarbonate level present, then you know that there's a mixed acid-base abnormality present. So that's actually a very important thing to recognize. You cannot fully compensate, you cannot overcompensate. Let's talk about the first line of acid-base defense here, that of buffer compensation. A little bit different as far as what occurs extracellularly versus intracellularly. The two work together to overall keep the body in homeostasis. The intracellular component is able to correct more. You've got about an 800 millimolar correction capacity intracellularly. Extracellularly, you've got about half that, about a 400 millimolar capacity. Extracellularly, basically, we're talking almost purely about the carbon dioxide, carbonic acid, bicarbonate buffer system. 95% of extracellular buffer compensation occurs through the carbonic acid pathway. There is some smaller amounts done by phosphates, accounting for about 5%, but for the vast majority of extracellular buffer compensation is through carbonic acid. Intracellularly, again, carbonic acid is a big player. Over 40% of intracellular buffer compensation is done through the carbonic acid pathway, but we see that a number of proteins, particularly those proteins with the histidine amino acids on it, do a great deal of the intracellular buffer compensation, with phosphates and components of bone comprising a portion as well. But overall, within the body, as we said earlier, the carbonic acid pathway is the main means of buffer compensation. The second line of defense is respiratory compensation. So you're able to either slow your rate of breathing and decrease your depth of breathing in response to alkalosis in order to increase your PCO2 relative to an increase in bicarbonate, or more often the case for us clinically as surgeons, we're dealing with patients who are breathing faster and breathing deeper in response to metabolic acidosis. So respiratory compensation, you can vary your rate of breathing, the depth of breathing, and blow off a variable amount of CO2 in order to compensate for changes in the level of bicarbonate. And again, clinically, the most common scenario in which we'll see this is patients who are acidotic, usually metabolically acidotic, secondary to hypoperfusion in the surgical patient or in the trauma patient. And in order to maintain the pH at an appropriate level, the patient hyperventilates and blows off more carbon dioxide to decrease the PaCO2. Now, the thing is that patients can only do this for so long, and then they become exhausted. And you'll see patients who are compensating, and if you're not watching them closely, they will flat out crump then in a very short interval of time as they finally become so fatigued they can no longer hyperventilate, they can no longer breathe deeper in order to maintain that low level of PCO2, and those are patients that need to be intubated, and then we can have the ventilator do the work for them in order to maintain their pH at an acceptable level while we then correct the underlying problems with resuscitation or surgery or a combination of both. So hypercapnia, hypoxia, and acidosis, how's this work? It works through the chemoreceptors, primarily located around the carotid body, but also some centrally, which respond by increasing the depth and rate of ventilation. On the other hand, if you've got actually an alkalotic situation, then the opposite occurs. The chemoreceptors are not stimulated, and so your breathing slows down. Now, there are boundaries to how much you can compensate, and those boundaries actually help us in determining as to whether a single metabolic abnormality in acid base is present or whether it's a mixed abnormality. In the setting specifically of metabolic acidosis, the amount that you're able to compensate from a respiratory standpoint is 1.5 times the bicarbonate level plus 8 plus or minus 2. So, for example, if you have a patient who's become a metabolically acidotic with a bicarbonate of 15, your expected PaCO2 equals 1.5 times 15 plus 8 plus or minus 2, which gives you a range of 28.5 to 32.5 for your expected PaCO2. If the PaCO2 which is measured is actually less than that, then you know that something else is going on, that you have a concurrent respiratory alkalosis. On the other hand, if the PaCO2 is greater than 32.5, in this example, you know then that you're actually overbreathing even for the presence of the acidosis, and you're actually I'm sorry, I misspoke. If, however, your PaCO2 is greater than 32.5, you know you're not getting the compensation that you should, and so you have some concurrent component of respiratory failure or respiratory acidosis. And so that, for example, might be the patient who's got a metabolic acidosis that's compensated for a while but is now becoming fatigued, is no longer able to compensate adequately, and that would be a very important thing to pick up on. And so when you see somebody that you've diagnosed based on their blood gas with metabolic acidosis, the next step, and we'll talk about this more in depth, is to determine, do they have appropriate respiratory compensation? And this formula of 1.5 times the bicarbonate level plus 8 plus or minus 2 helps us do this. On the flip side, for metabolically alkalotic patients, the expected PaCO2 is 0.7 times your bicarbonate level plus 21 plus or minus 2. So, for example, a patient who's metabolically alkalotic with a bicarbonate of 40, if you plug this into the formula, you see that it's 0.7 times 40 plus 21 plus or minus 2 gives us a range of 47 to 51 for an expected bicarbonate level. If you, for an expected PaCO2 level for that level of bicarbonate. If you get your blood gas and your PaCO2 is actually less than that, then you know that you have a concurrent respiratory alkalosis. On the other hand, if your PaCO2 is greater than 51 in this particular example, you know that you have a concurrent respiratory acidosis. And once again, I would remind you that probably the most frequent area where it's important for us to exploit the respiratory compensation in surgical patients at least is with patients with severe metabolic acidosis, typically from lactic acidosis, which we may need to hyperventilate to keep the pH within an acceptable range. And so it's not infrequent that I'll intubate a patient maybe who is not yet in ventilatory failure in order to be able to better compensate, better maintain that pH at an acceptable level. And we're going to see that that's a much better way to do it than trying to give them mega doses of bicarbonate. The administration of sodium bicarbonate is for the most part to be discouraged in lactic acidosis, at least until you're at least when you're above a pH of 7.15, and we'll talk about that more in a bit. Okay, so the more delayed, but in some ways the most powerful means of compensation is renal compensation. And this is done in a twofold fashion, as we'll talk about, but again, this is the slowest to occur, but in many ways is the most powerful. The way the majority of renal compensation occurs is by altering the amount of bicarbonate which is reabsorbed from the collecting tubules. This typically begins within 6 to 12 hours of your PaCO2 being thrown off one way or the other, but is not fully developed until 2 to 3 days. And if you have, for example, bicarbonate level, which is, in the normal to acidotic range, you really try to preserve bicarb. You get reabsorption back into the plasma of essentially all bicarbonate when your bicarbonate levels are less than 27. However, once you start to become significantly alkalotic, then the body kind of shuts down that bicarbonate reabsorption somewhat, and you start to pee out some of that bicarbonate in order to compensate and prevent you from becoming, in order to compensate, I should say, for the alkalosis. And that involves carbonic anhydrase, which is the enzyme, of course, responsible for the carbonic acid cycle, and that actually is occurring intracellularly in the tubular lumen. Intracellularly in the renal tubular cells as pictured here. So basically, the take-home message is that renal compensation, you normally reabsorb all of your bicarbonate until you start to become alkalotic, and then you can shut down your bicarbonate reabsorption in the distal convoluted tubules and then the renal tubulars to offset that. There is, however, also some acid secretion which occurs renally, and you can eliminate variable amounts of non-volatile acids. The main way that this is done is through the ammonium ion. Normally, if you've got normal acid-base balance, we excrete about 30 to 50 milliequivalents per day of acid as ammonium ion. If, however, you've got a significant metabolic acidosis, which has been ongoing for a while, you can increase that up to 5-fold times and get rid of as many as 250 milliequivalents per day with metabolic acidosis. So you can actually have an active secretion of acid from the kidney through the ammonium ion. To a lesser degree, you can also get some amount of phosphoric and even sulfuric acid urinated out, but this is a little bit smaller player, or a significantly smaller player than is the ammonium ion, 10 to 40 milliequivalents per day of acid at max, as compared again to the 250 milliequivalents per day. And so renal compensation, you can again alter the amount of bicarbonate you're absorbing, and you can secrete or you can alter the amount of acid which you're secreting, primarily through the ammonium ion. And it's a lack of being able to do this renal compensation that results in severe renal failure patients developing acidosis. Okay, let's look at the respiratory side now of things. So we've looked at metabolic acidosis, metabolic alkalosis, and kind of the changes which occur with them and the compensations which occur. What about when your primary abnormality is on the respiratory side? Certainly most commonly we're dealing with respiratory acidosis here, but respiratory alkalosis will also sometimes occasionally be significant to us. This is important because you can get an increased amount of respiratory compensation over time. And so there's actually two levels of compensation with respiratory alterations, an acute phase and a chronic phase. And by acute phase, we're usually talking about 48 hours because that's, again, how long renal compensation takes to develop. So the difference between the acute and the chronic here is 48 hours, although obviously there's going to be kind of a fuzzy area in between the two. With acute respiratory alteration, so somebody who develops acute onset of respiratory failure or other respiratory issues, occasionally there will be respiratory alkalosis in a patient who's becoming septic, the pH expected equals 7.4 plus 0.008 times the difference between 40 and the measured PaCO2 level. So you plug in the PaCO2, which the patient has, subtract that from 40, multiply it by 0.008, and add that to 7.4, and that gives you what your expected pH would be for acute respiratory issues. For example, if you have an acute increase in the PaCO2 to 60, such as might occur in ventilatory failure, your expected pH for that would be 7.4 plus 0.008 times 40 minus 60. That would give you an expected pH of 7.24. If your pH is actually less than that, then you know that you must also have a metabolic acidosis going on. On the other hand, if your pH is greater than that, then you know that you must have a metabolic alkalosis going on as a mixed disorder. On the other hand, if your PaCO2 is being blown off excessively down to 20 in this example, then you plug the numbers in and you have 7.40 plus 0.008 times the difference between 40 and 20, which actually gives you an expected pH of 7.56. And again, if you're outside of that range significantly, then you may have a mixed, or you do have a mixed disorder. When you've had a long period of time, by definition, you're talking greater than 48 hours, but certainly when you're dealing with a COPD, or for example, that has some amount of chronic respiratory failure all the time, then the amount of renal compensation is greater, and so your expected pH changes less. And so, for example, if you have a chronic respiratory failure with an increase in PaCO2 to 60, such as a chronic COPD, or for example, then the expected pH is 7.34, and if you're outside of that range one way or the other, you've got a second abnormality which is present. Again, full renal compensation takes 48 hours to develop, and you can see that it does afford a not insignificant amount of pH normalization. Now, before we go on with further discussion as far as how to measure acid-base abnormalities, it's important to take a look specifically at metabolic acidosis, because there's actually two broad categories of metabolic acidosis, and a little bit later in our review we'll go over each of these specifically, at least in passing. But metabolic acidosis is divided into an increased or a high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. High anion gap acidosis is what we deal with probably most commonly, at least in our acutely ill surgical patients, and the vast majority of this is due to lactic acidosis. Our body is dependent upon oxygen for the maintenance of energy, the production of ATP. If you lack oxygen as the final electron receptor, electron transport doesn't work, and pyruvate, instead of going down the citric acid cycle, gets shunted into the lactic acid cycle, which is a much less efficient means of producing energy, but does produce some energy in a backup mode, but also creates a buildup of lactate as a side effect. Ketoacidosis, as you see with severe diabetics, can also result in a high anion gap acidosis. Certainly end-stage renal failure can produce a metabolic acidosis with an increased anion gap. And you can occasionally see this due to other causes. We'll talk momentarily a little later in the talk about D-lactic acidosis and certain toxin ingestions. Probably the most common toxin that you see this with is metformin, and I have seen a couple cases of significant metformin toxicity, which can present as a high anion gap metabolic acidosis, and occasionally this is seen as a manifestation of malignancies. But what you have with an increased anion gap metabolic acidosis is an increase in the amount of non-volatile acids which are present. Again, most commonly lactic acidosis in the surgical patients. Normal anion gap acidosis is not infrequently seen, however. Particularly patients that have severe diarrhea will present with a metabolic acidosis with a normal anion gap. Hyperchloremic metabolic acidosis, which is most often iatrogenic from normal saline infusions, is very frequently seen. You can also see it with early renal failure, with renal tubular acidosis if you give too much cetazolamide, or occasionally if a patient has happened to have had a ureteroenterostomy, this can sometimes complicate it. But for the most part, in our surgical patients, at least general surgical patients, we see this as a manifestation of diarrhea or the saline that we give patients, and this is reflective of a decrease in bicarbonate. So increased anion gap acidosis, you're talking about an increase in the non-volatile acids floating around. Normal anion gap acidosis, you're talking about a decrease in the amount of bicarbonate which is present. Well, what the heck is the anion gap that we're talking about? Well, your blood can't be charged. Your blood has to have electrochemical neutrality or balance, and so the total amount of cations, or the positively charged particles, have to equal the amount of anions, or negatively charged particles. For the big players are sodium, chloride, and bicarbonate, but then in the midst there you also have some unmeasured cations and some unmeasured anions. So in essence, the sodium, which is the predominant cation present in the bloodstream, or present in the plasma, the sodium plus the uncharged cations, the overall balance has to equal that of the anions, the chloride plus the bicarbonate plus any unmeasured anions. So by simply rearranging this, now we can see the formula there. Sodium minus chloride minus bicarbonate should equal the unmeasured anions minus the unmeasured cations. And it's this difference, the difference in the unmeasured anions and the unmeasured cations, that is referred to as the anion gap. And if you have a patient, for example, with diabetic ketoacidosis, and you've got a lot of keto acids floating around, then you've got an excessive amount of unmeasured anions, and that number will be increased. And so that patient will have an increased anion gap. The normal anion gap differing somewhat between different labs, but most are in the range of 8 to 12. If you're within that range or under it, then it's referred to as a normal anion gap. If it's above that, then it's an increased anion gap. And that's important from a differential diagnostic standpoint as to, number one, what's causing your acidosis, which is important, and number two, for example, I mean, if you've got a patient you've taken, from surgery, and they've got a high anion gap acidosis, that means you've probably not resuscitated them appropriately. On the other hand, if you've got a normal anion gap acidosis, maybe your amount of resuscitation is appropriate, but just the fluid that you're using might be inappropriate. For example, you might be inducing that with normal saline, and they might not need more fluid. They might actually need less fluid, or at least a different type of fluid. Looking at, so what are these unmeasured anions and these unmeasured cations? Well, certainly the unmeasured cations we actually do measure in many instances: calcium, potassium, magnesium. Those are the main contributors to the unmeasured cations. More important for us to understand, though, is what are the unmeasured anions. Overwhelmingly, the most important one is the serum albumin level. Albumin is an anion, and it technically is an unmeasured anion. Although we can measure its number, it doesn't. It's not something that we look at when we calculate necessarily the anion gap. Other players: organic acids, phosphate, and sulfate, but albumin is the big player. And this is very important because you can have a patient who has a measured anion gap, and you get the anion gap. It comes as a printout with the chemistry panels now, but you have to look at that anion gap in the light of what the patient's albumin level is, because a patient with hypoalbuminemia, which we see in many of our surgical patients, either due to malnutrition or just a dilutional effect from the IV fluid we've given them, you have to, and that can falsely decrease your anion gap. So you have to correct for any hypoalbuminemia present in order to accurately measure the true anion gap. And that correction factor specifically is to take the measured anion gap and add to it 2.5 times the difference between 4.5 and your albumin level. So, for example, if you've got a patient with a very poor albumin level, which we see all too frequently of around 1.5, and their measured anion gap is 8, their corrected and actual anion gap is actually 8 plus 2.5 times 3, which means it's 15.5, which means that that patient actually has an elevated anion gap. And so that's a very important thing to keep in mind when you are measuring and you are looking at the anion gap, is to consider it in the light of the albumin level. A little less relevant, but still important to teach, at least from an academic standpoint, is the so-called gap. This is important really only with high anion gap metabolic acidosis. If the increased anion gap metabolic acidosis is the only disturbance present, then 26 minus the gap elevation, so the difference between the upper limit of normal, usually 12, for your anion gap, and the measured anion gap, should be your approximate bicarbonate level. And if your bicarbonate is higher than that, then that means you've got a concurrent metabolic alkalosis present. If your bicarbonate is lower, then that means you've got a concurrent non-gap metabolic acidosis present, and you actually have a mixed disturbance. For example, if your anion gap's 15, your expected bicarbonate should be 26 minus 15 minus 12, which is 3, or 23. If your bicarbonate is less than that, then that means you've actually also got a non-gap metabolic acidosis as well. So maybe you should stop with the normal saline and resuscitate the patient with something else, for example. Or maybe you need to be mindful of maybe some diarrhea, which is present, contributing, as well as other things to the acidosis. On the other hand, if your bicarbonate level is significantly above that, then there's a concurrent mechanism for metabolic alkalosis present. So the gap is something we measure only it's really only of significance when you are dealing with a high anion gap metabolic acidosis. So in summary, acid-base analysis, and we'll go over this more in the talk, is ensure that your data are valid. Make sure you've not got a hemolyzed specimen or anything. Know your normal values. Normal pH is 7.35 to 7.45. Normal PaCO2 is just 35 to 45. Easy to remember those two in conjunction. Normal bicarbonate levels between 24 and 28. Normal anion gap is 8 to 12. And the first thing you look at is the pH. If you're low, it's acidosis. If you're high, it's alkalosis. And then you look at the bicarbonate or PaCO2, whichever you want to look at. But for example, I like to look at the bicarbonate. If the bicarbonate's down, then you're going to be dealing with a metabolic alkalosis. If your bicarbonate's up, you're going to be dealing with a metabolic acidosis, and the same goes for PaCO2. So determine whether it's metabolic or respiratory. determine whether you've got appropriate compensation then. So then you plug in those compensation formulas and see if you've got appropriate compensation or if there's evidence that another disturbance is present. Then you check your anion gap if it's appropriate with acidosis. Correct the anion gap for hypoalbuminemia. And then if you have an increased anion gap, metabolic acidosis, also check the gap. So here's an example of how you would do this. Fairly straightforward problem. You've got a 70-year-old male with acute onset of abdominal pain. You get an ABG on the patient, reveals a pH of 7.66, a PCO2 of 22, a PO2 of 76, a bicarbonate level of 25. You get a concurrent chemistry panel, which shows those numbers, particularly the chloride level of 95 and the CO2 or the bicarbonate level of 25. BUN is a little elevated, and the patient's glucose is slightly elevated. So looking at this, your first step is to determine what is your pH and what is the primary abnormality. pH is above 7.45, so that's an alkalosis. And you look at your numbers and you see that your PaCO2 is decreased there below the normal level at 22, and so that means you are dealing with a respiratory alkalosis specifically. And then you plug in your compensation formula. Is this the expected pH you would expect to have? You plug that into the formula for acute respiratory decompensation, and 7.40 plus 0.008 times the difference between 40 and 22 ultimately comes out to an expected pH of 7.54. But we see that the pH is 7.66, and so that means in addition to the respiratory alkalosis, there is also a concurrent metabolic alkalosis. And so you have a mixed acid-base abnormality here of a respiratory alkalosis and a metabolic alkalosis. The gaps are not relevant in this case since we're dealing with alkalosis. So final analysis is a mixed respiratory and metabolic alkalosis. Now, what I have gone over in this approach is kind of the way I was taught in medical school, and I think is the way most people look at acid-base methodology. There is a more complex way of looking at this put forward primarily by a physiologist named Stewart, the so-called Stewart methodology, Canadian physiologist. And you will see this promulgated in some of the critical care literature as he emphasizes the limitations of the so-called traditional acid-base methodology, and there are some limitations. However, they appear not to be particularly clinically relevant. Stewart emphasizes the importance of ion movements across membranes and the effects on pH, and emphasizes that, and talks a lot about weak acids and proteins and the strong ion difference and a number of things, and it becomes very complex and such that you kind of have to have a program such as this one here to be able to do your acid-base analysis. I like the way that Dr. Marino kind of dismissed the Stewart methodology, if you will, and I quote from Dr. Marino's text, that such alternate methods of acid-base analysis tend to involve complex equations and are not easily implemented at the bedside. Furthermore, there is no convincing evidence that other systems of acid-base analysis provide any real clinical benefit over the traditional method, and I would echo Dr. Marino's feelings on that. So I think there is a more complex way to look at this. I'm not sure that you get enough bang for your buck to make it worthwhile, and I've not embraced the Stewart methodology, and I would not, and I would encourage you to stay away from it and keep simple things that can be kept simple. I think it is important, though, to recognize that ion charges do make a difference. And this becomes important, particularly when we talk about normal saline and chloride. If you add anions, you're basically adding excessive negative charge. And this results in decreased bicarbonate reabsorption in order to maintain charge neutrality. And so addition of anions has an acidifying effect. Addition of cations, on the other hand, have an alkalinizing effect, as that excess positive charge increases the amount of bicarbonate reabsorption. This is important primarily in when we look at normal saline and non-GAP metabolic acidosis. If you look at the composition of normal saline, and it'll be important for you to know this for Dr. King's lecture and for your patient's care, normal saline is composed of 154 milliequivalents of both sodium and chloride. Now you compare that to normal plasma. Normal plasma levels of sodium between 135 and 145, so a little bit excessive sodium, but a whole lot excessive on the chloride, 101 to 111 kind of being the normal range for chloride level in milliequivalents per liter. And so what you're doing when you infuse normal saline into a patient, or for that matter any fluid, half normal saline, quarter normal saline, any fluid with equal amounts of sodium and chloride, you're giving a relative excess of chloride compared to what is physiologically normal. And as a result, you can get with this, if you get a lot of it, a hyperchloremic normal anion gap metabolic acidosis, because you are essentially adding excessive anion. Now, you can sometimes get behind the 8 ball and find out that you've got a patient that's got a pretty significant metabolic acidosis. It's a normal anion gap, and you've probably at least in part created it if you've been using normal saline. It's not that normal saline's evil. It's just you have to understand the downsides of it or any fluid that or treatment that you give. And in that instance, the treatment for non-anion gap metabolic acidosis is bicarbonate. You can either, if you have to give IV boluses, or more commonly we'll give IV infusions, which can be created by taking D5W and adding 2 or 3 amps of sodium bicarbonate to it. Each amp of sodium bicarbonate contains 54 milliequivalents of both sodium and bicarbonate. So, you're looking at 108 if you're adding 2, or a bit more if you're adding 3. You can also do this with just plain sterile water, adding sodium bicarbonate to it. Now, obviously, we can't normally give sterile water. That'll lyse the cells, but water plus the amps of sodium bicarbonate is perfectly acceptable to give. And so by doing this, you're giving a fixed cation with a labile anion, which goes away, that of the bicarbonate. And so this enables you to create or to correct such an acidosis. And this can be particularly important if you have a patient that you're getting ready to get extubated, but they've got a bit of an acidosis. It's not an increased anion gap thing, so you don't think it's from under resuscitation, but maybe it's just that you gave too much saline or one of the other issues which can cause the non-anion gap metabolic acidosis. But if you extubate them, they're going to have to work harder if they're acidotic to overcome that. Therefore, they might fail extubation. So it's very frequent that you will want to give an interval of treatment of such a non-GAP metabolic acidosis prior to extubating the patient. Now, I think the understanding of the ion charges can help you in understanding what's appropriate IV fluid to give as well. We've talked about normal saline and how it can have an acidifying effect due to the administration of the due to the administration of excessive amounts of chloride relative to the normal patient's physiologic levels. Lactated ringers, on the other hand, contains 130 milliequivalents of sodium per liter and 109 milliequivalents of chloride. So a much more physiologic level of chloride with lactated ringers. And here you're giving a bit more cations relative to the anions you're giving, and so you actually have an alkalinizing effect when you give lactated ringers, which seems paradoxical because you talk about giving lactate, but that lactate is actually, that is in lactated ringers, number 1, is a small amount, and number 2 is quickly metabolized to bicarbonate. And so although it seems a bit paradoxical, when you give lactated ringers, that actually has a slightly alkalinizing effect. On the other hand, normal saline has a slightly acidifying effect. In small volumes, not a big deal, but if you have a patient, for example, that's acidotic, and all other things are equal, their potassium's okay and things of this nature, then lactated ringers is probably a better resuscitation fluid for that patient. On the other hand, if a patient's suffering from metabolic alkalosis, then normal saline might be a better resuscitation fluid in that setting. It is a misnomer that lactated ringers is contraindicated with lactic acidosis. If anything, it's better to give than normal saline, so long as your potassium's okay. Okay, so let's look a little bit closer now at the differential diagnosis of metabolic acidosis. In particular, we'll focus our attention initially here on increased anion gap metabolic acidosis. Again, the majority of these cases which we see from a surgical standpoint are in the presence of lactic acidosis, where once again you have the lack of due to shock and poor perfusion, a lack of oxygen to the peripheral tissues to act as the final electron receptor. The citric acid cycle gets shunted off at the level of pyruvate, and you have lactic acid which builds up instead, providing you a little bit of energy, but certainly inefficient as compared to the normal pathway, and it can result in lactic acid building up. And basically the treatment for this is aggressive fluid resuscitation. Give them blood if they need blood. If it's not a bleeding patient, then lactated ringers is currently probably the best thing to give, with some exceptions, and treat the underlying problem. If they're septic, resuscitate them aggressively, and we'll talk in depth how to do that, but involves a lot of fluid in many instances, and then expeditious reversal of whatever the septic focus is. If it's a bleeding trauma patient, you can't resuscitate a bleeding trauma patient, but you can get them to the OR and you can stop the bleeding, and then you can resuscitate them. So lactic acidosis, which is the most common type of high anion gap metabolic acidosis. The treatment for that is resuscitation. The treatment is not bicarbonate. You'll see all too often these patients that are languishing with under resuscitation, even sometimes in the ICU, and people are pounding them with bicarbonate, and that can actually be problematic, as we'll talk about in a moment. The treatment for lactic acidosis is resuscitation. Ketoacidosis, not something we deal with as commonly, but certainly can be seen in our patients. The medical guys deal with this all the time. The treatment for it, if it's a diabetic issue, is to treat the ketoacidotic crisis as appropriate per protocols. We will see this sometimes, though, in alcoholic patients. Alcoholic patients can, when you drink excessive amounts of alcohol, instead of eating, then you can become deficient in thiamine. And when you become deficient in thiamine, your pyruvate dehydrogenase doesn't work anymore, because thiamine is a cofactor for that enzyme. And so you can see basically ketoacidosis occurring in the setting of alcoholism fairly quickly, and the treatment for that is actually thiamine supplementation along with glucose and appropriate fluid resuscitation. And so alcohol is one toxin which can give you a high anion gap metabolic acidosis. Others, less commonly seen, probably not seen at all in the surgical service, methanol and ethylene glycol. Metformin, though, is significant and is interesting. You can get sometimes a profound metabolic acidosis from patients on metformin, especially if they have a CT scan with IV contrast and then continue to receive their metformin or have received it within 24 hours. And the treatment in that setting actually is not just fluid resuscitation, but is bicarbonate, and that's the one high anion gap acidosis that you will treat kind of routinely with bicarbonate. And I had one lady actually that developed this on my service. We actually had to intubate to help her to blow off her PCO2 enough to correct her and keep her out of life-threatening levels of low pH. D-lactic acidosis is interesting. We'll touch upon that in just a moment. Again, just to touch upon lactic acidosis, once again, it's the most common acid-base abnormality in surgical patients. It's a result of impaired tissue oxygenation, favoring anaerobic metabolism, and it's part of the lethal triad of trauma. And you'll see this figure a lot here when we go through the trauma lectures. But acidosis, hypothermia, coagulopathy, it's a positive feedback cycle, which can be very negative for the patient. And we've got to prevent each of these arms from happening. And prevention, an ounce of prevention is worth a pound of cure here. Again, treat the underlying source. And while doing so, aggressive fluid, or if appropriate, blood product resuscitation. If you need to, enhance the patient's respiratory compensation, i.e. intubate them and help them to compensate. Bicarbonate is not the primary mode of therapy, only if the pH starts to dip below 7.15, because at that point you're at risk for primary cardiac contractility issues. There's a lot of problems with giving bicarbonate as the primary treatment for lactic acidosis. One is you tend to overshoot, and so once you get the patient resuscitated, they go into metabolic alkalosis, which can sometimes be just as deadly. But also, there's the potential that if you give rapid infusion of sodium bicarbonate IV, trying to improve the pH of the patient, you can generate a large amount of carbonic acid in the ECF, the extracellular fluid. And if you're not able to blow that off quickly from a ventilatory standpoint, then excess carbon dioxide can actually shift intracellularly and lead to a paradoxical increase in intracellular metabolic acidosis, essentially making the problem worse. The CO2 backing up, if you will, in the venous system. Also, large amounts of sodium bicarbonate can generate hypernatremia. And there are issues with calcium binding as well. So again, I think I've beat this horse enough to make it dead, I guess. But bicarbonate therapy, if your pH is dipping below 7.2 or certainly below 7.15, okay, use it while you're doing aggressive fluid resuscitation, but do not use bicarbonate therapy as the primary method of treating a high anion gap high anion gap acidosis unless you're pretty darn sure that it's due to metformin or some other medical cause. Lactic acidosis you don't want to use as a primary treatment. And it's interesting, we tend to give it in CPR a lot, and I do it as well, but there's really no evidence that's of benefit during CPR. I'll probably continue to do it because it just kind of seems right that if somebody's pH is 6.9, then you're going to give it. But there's not actually good evidence of benefit during CPR. Again, metformin-associated lactic acidosis is kind of a little unusual in that it does respond well, not just to fluids, but also bicarbonate. And in some instances, dialysis is even needed. Now, when we look at acidosis as compared to alkalosis, it's interesting that they have differing effects on the oxygen hemoglobin dissociation curve. The black line here is kind of right in the middle, and a right shift of the curve basically means that you're letting go of oxygen easier, and that's kind of what you want. You want hemoglobin to let go of oxygen in your peripheral tissues so that those peripheral tissues can use that. So things which shift the oxygen hemoglobin dissociation curve to the right are favorable, within limits, and acidosis actually does that. Fevers actually do that. On the other hand, alkalosis and hypothermia shift the curve left. They cause hemoglobin to hold on to oxygen tighter, and that's a bad thing in the setting of shock. So the message here basically is you'll tolerate a little bit of acidosis, particularly metabolic acidosis, and actually maybe do a little bit better in a shock situation. So you don't want to over-treat the pH, and that's another reason that you don't want to load the patient up with huge amounts of bicarb. A patient will live fine with a pH of 7.28, as long as they're able to ventilate adequately to make sure it doesn't get much less than that. A patient will live okay with a pH of 7.3 and maybe do better at that than they will with a pH of 7.5, for example. And part of that reason is because of the effects of alkalosis, or acidosis on the oxygen hemoglobin dissociation curve, with alkalosis causing a disfavorable left shift and acidosis causing a favorable right shift, within reason, obviously. D-lactic acidosis, we'll just mention for a moment, is interesting. You'll see it in these old jejunal ileal bypass patients, which you don't see many of them anymore because that procedure is not done anymore, but also can be seen in short gut patients. With that, you have a decreased ability to process carbohydrates appropriately. And so if those patients eat too much carbohydrates or ingest too many carbohydrates, you can get an excessive amount of glucose and starch being delivered to the colon as it's not broken down appropriately. With metabolism, then, D-lactic can build up, can be absorbed systemically, and can actually lead to a D-lactic acidosis, which is really slow to clear because it's not recognized by the normal L-lactate dehydrogenase. And it's also not picked up by lab measurements of lactate levels. It's not picked up on the assay. So what you'll get on the labs in these patients is an increased anion gap metabolic acidosis, but with a normal lactate. So you'll be scratching your head, why in the world did they have this? Well, it's actually a lactic acidosis, but it's a D-lactic acidosis. This can lead to significant neurological symptoms of confusion and ataxia, slurred speech. It basically looks like they're drunk, memory loss. The treatment in this setting is bicarbonate, antibiotics as well, because there's a fair amount of overgrowth, which is an issue in these patients as well, and then certainly decreasing the amount of carbohydrates the patients get. Never seen a case of this, but there is a potential. You might see that particularly if you have a jejunal ileal bypass patient or a short gut patient. Okay, let's turn our attention now away from increased anion gap acidosis and look at normal anion gap acidosis. Deal with this not infrequently. Again, when we deal with it most commonly on our surgical services due to diarrhea or fistulas. Just today I have a lady who unfortunately has leaked after her oversow of a perforated ulcer, and came in and looked at her labs, and her CO2 on her chemistry panel is down to 16. And this is related to her fistula output. So I'm going to treat her now with, some bicarbonate infusion. Fortunately, she's compensated for it well, so her pH has stayed normal because she's had appropriate respiratory compensation, but she's a COPDer, so I don't want her to work too hard. So fistulas and diarrhea can lead to loss of bicarbonate in the fistula output or in the stool relatively. We've talked about saline infusions and how those can cause a normal anion gap acidosis. You can also see it with early renal failure or renal tubular acidosis. Acetazolamide or Diamox can cause it. I use Diamox sometimes, and I'll explain the setting in which it's useful. But if you give too much, it can lead to a normal anion gap acidosis. Lasix, on the other hand, the most common diuretic we use, tends to make you alkalotic. And sometimes, if I have a patient I'm massively diuresing, we'll kind of balance and use both Lasix and acetazolamide, usually alternating the doses in order to kind of keep your acid-base status at a normal. You got to be careful. If you over-diurese somebody with Lasix, they can develop a pretty significant metabolic alkalosis. Acetazolamide can allow you to continue to diurese these patients while also keeping their acid-base status within the norm. Now, unlike increased anion gap acidosis, where in most instances, or at least lactic acidosis, where you'll avoid bicarbonate, here bicarbonate is really kind of the treatment of choice. Again, particularly important in a patient with a tenuous respiratory status, such as somebody you're just getting ready to extubate. Then you'd really like to have that acidosis treated, and bicarbonate, as we talked about administering, can be very helpful in obtaining that. Let's look at the flip side now, metabolic alkalosis. A classic question on boards and other tests is, the patient that has an NG tube in place, what type of abnormalities will you usually see? And you will typically tend to see a hypokalemic, hypochloremic metabolic alkalosis, because you're sucking out primarily hydrogen and chloride, and then because of the effects on the sodium-potassium, sodium-hydrogen exchangers, as you decrease that and they become alkalotic, you also tend to get a decreased potassium as well. So GI losses is one of the most common causes of metabolic alkalosis that we see, such as from nasogastric suction or also vomiting, or in some instances diarrhea. So diarrhea can give you both an acidosis or an alkalosis, kind of depending on how much chloride is coming out in the diarrhea. Diuretic therapy, again, overusage of Lasix can give you metabolic alkalosis, and you'll see that very commonly. Those are the most common type of chloride-responsive metabolic alkalosis. We'll see chloride unresponsive, adrenal hyperfunction, so excessive adrenal function, such as you see with Conn syndrome or Cushing syndrome. What does aldosterone, which is can be present in increased amounts, particularly in Conn syndrome, but also to a lesser degree in Cushing syndrome? What does that cause in the renal tubulars? It causes an increase in sodium reabsorption, and with that you get increased hydrogen excreted, and so those patients will tend to become alkalotic. You can occasionally see this with refeeding syndrome, usually in association with low magnesium and low phosphate, so something you have to look for when you're refeeding somebody who's had poor nutritional status for a long instance, for a long period of time, I should say. The so-called contraction alkalosis, again, is basically when you've got a loss of significant volumes of bicarbonate-free fluid. The main example, again, is overdiuresis. So overdiuresis is a type of the so-called contraction alkalosis. You've dried them out too much, but can also occur due to NG losses, or in cystic fibrosis patients, you can get it from sweat losses. Not typically a problem for us typically, but NG losses and overdiuresis is a cause of contraction alkalosis, and you have to give them some volume back. And in this instance, the best type of volume to give them would be normal saline to kind of reverse the effect of the alkalosis. Other treatment options in metabolic alkalosis, we talked about the utility of Diamox or acetazolamide, a carbonic anhydrase inhibitor, which will actually tend to make you slightly acidotic, I apologize. The relationship between hypokalemia and metabolic alkalosis, again, there's several levels of this, but just looking at it on a transcellular cation exchange, if you have, there's a couple layers to this, I should say. The transcellular cation exchange is one. Basically, if you have a low amount of potassium, you have, in order to offset that, less you're getting rid of more hydrogen, and therefore that tends to make you alkalotic. The same thing happens in the distal convoluted tubule, where you have hydrogen and potassium going opposite ways, and if you have less potassium to reabsorb, you're getting rid of less hydrogen, you're getting rid of more hydrogen, and therefore the patient's becoming alkalotic, and decreased chloride reabsorption plays a role here as well. Post-hypercapnia alkalosis occurs due to a rapid correction of chronically elevated PaCO2, and this is because the chronic renal compensation takes longer to shut down, and so it's continuing to act as it would for somebody with a high PaCO2, and so you can actually offshoot and become alkalotic. Normal saline can help in this instance by giving chloride to help offset this. You have to be careful for other reasons with acutely decreasing the PaCO2, as this can also acutely increase your cerebral intracellular pH, which can cause bad neurologic sequelae as well. Okay, looking at the respiratory disorders, not going to spend a lot of time here. Respiratory acidosis, basically this is ventilatory failure. It can be due to CNS depression, either due to, somebody with a bad head injury or somebody with oversedation, for example. Neuromuscular disorders where the patient's too weak to breathe. Thoracic cage limitation, such as patients with pulmonary contusions, and multiple rib fractures can significantly impact upon their ability to ventilate appropriately. Restrictive lung abnormalities, obstructive lung diseases, COPD, etc., or certainly ventilator malfunction are things which can cause respiratory acidosis, which is basically synonymous with ventilatory failure. And the treatment is support the ventilation, intubate the patient if other means are not going to work, and in most instances best to move forward aggressively and then hopefully get them extubated sooner, but you in many instances don't have a lot of time to lose. Respiratory alkalosis, don't see this often on our service, but what you can see, and where it's really important to recognize respiratory alkalosis, is it can be the initial abnormality noted in developing sepsis. It's almost like the patient senses that things aren't right. They start to hyperventilate, and it's not an overcompensation per se. I don't know how to describe it other than to just say it's an early sign of sepsis before you get into the point more often of a metabolic acidosis. You can also see it with pregnancy, liver failure, hyperthyroidism, and in certain CNS disorders. But the most important thing to remember is in the setting of perhaps early sepsis. One thing just want to touch upon as we conclude, you don't always have to have an ABG. ABGs clearly are more accurate than venous blood gases are, but capillary blood gases, venous blood gases correlate reasonably well with ABGs in regards to PaCO2, pH, and bicarbonate. Now, obviously, you can't count on them for the PaO2, but, you've got your O2 sat. So in many instances, you don't necessarily have to stick a patient's artery over and over again. You can get much of the information you need from a venous blood gas. So I apologize. It's my first time kind of doing the lecture in this format. I think I was a little long-winded than usual. Hopefully it wasn't too painful to listen to, and hopefully as we go forward, this will be a more efficient way to get this information to you and for you to study. Thank you for your patience.